Thanks very much, Theo. So, Tim, that was a great presentation, and I think that one of the things I would say is that the changed environment that we need, that you have argued convincingly for and given us a glimpse of, is indeed very strongly aligned with the changed environment that C3-Cloud is a catalyst for. I mean, C3-Cloud has achieved a number of things that everybody's heard today. I won't repeat them, and you've highlighted a few things in your own talk just now that C3-Cloud has helped enable. But I think that when I started working within the project on this particular topic, I had a brief that was to look at some of the organizational change challenges. Actually, I'm realizing I haven't, maybe I should just show my camera for a minute or so. Otherwise, I'm doing the talking and no one knows what I look like, but maybe you will do anyway. When I was looking at what we were trying to achieve, I could see 4 areas that I thought were going to be culture challenges that C3-Cloud would, in a way, expose, would rely upon, but could not itself change. These would be things that we would need to be environmental evolutions that would need to support successful use of C3-Cloud. It will work anywhere, but it will work really well if we tackle 4 things. One, which has been highlighted a few times today, is that in order for multidisciplinary teams to work cohesively, and also for some of the digital tools to work well, there needs to be a relatively complete information base. That is, the decision support, the computerized guidelines, but even clinical human decision making will work very badly if everybody is looking at an incomplete medication list, an incomplete condition list, doesn't have access to the allergy list, because these are held in silos in different parts of the health ecosystem. So C3-Cloud both catalyzes the integration. Roxy presented how EHR data is brought together, but also it requires that the underlying EHRs are reasonably complete, and reasonably complete in their structured and coded form, not at the moment buried in free text notes. And so this is a culture change about taking clinical documentation seriously that I think we're a catalyst for, but there need to be other movers in the field that help do that. The second area is about care pathway formalization. A lot of clinical care pathways exist because clinicians are either at some point they've read a guideline, or they've joined a clinical team, they've joined a hospital or a GP practice where certain practices of care pathway happen. They become mentally absorbed, they stay in the brain, and they get used in an ad hoc, informal way. They're not documented well, they're not shared with patients. Multidisciplinary teams only sometimes share that sense of a care pathway. Otherwise, everybody has a micro care pathway, which is their own black box, and others don't know how they work. So there's a real culture change about sharing and formalizing how you want to look after patients. Then the third one is about really opening up with patients. Yes, we have, in theory, shifted a little towards more openness with patients, shared decision-making, discussing with patients that you'd like to get the advice of a hospital specialist, or you'd like to change their blood pressure treatment, and explaining to them why. But that's not the same as a really co-created care pathway. That's not really the same as giving patients greater autonomy, which has to mean clinicians are having less autonomy over a patient. They're less in our control because they're more in their own control. That's another culture change. And the fourth area is about kind of reimbursements and organizational policies. Because if you have a mixed model of care across general practice, hospitals, or other care providers, in a new multi-morbidity aligned empowering care pathway, sometimes the organizations don't do the same volume of activity as before. Some people will do less, some people will do more. At the moment, the money doesn't follow that change. So some organizations would see adopting a modern integrated patient empowering model, whether it's C3-Cloud enabled or not, as destabilizing their financial flows, costing them more than they're being reimbursed for example, or giving them a huge profit because they're doing less but getting the same money. which no one complains about. So those are the things that I think are the hard problems. I mean, my colleagues may have expected me to summarize all of the organizational friendly changes we've made in C3-Cloud, but I decided I didn't want to sell C3-Cloud to the audience. I wanted instead to use my 5 minutes to expose you all to what are the changes that the health systems need to embrace in order to leverage the benefit of a C3-Cloud-like solution to the best. It'll work anyway, but it'll work even better if those 4 areas are taken seriously and proactively. So that's the pitch I wanted to make. And I don't know if you wanted to give Tim a minute to react, or Theo, if you, as the master of C3-Cloud, we didn't rehearse this bit, whether you want to react. But that was really the pitch I wanted to throw in. It's really a challenge to the whole audience. You've all got to be part of catalyzing those vital changes.
I think it's interesting, and I would allow Tim to give his reactions as well as a clinician. As a coordinator of C3-Cloud, I realized that in the UK, at least, we have been talking about integrated care and changing our organizational models for many decades. I think, as Tim said, this is not a new concept. What we have created is novel ICT infrastructure. We have done a lot of interesting research in terms of products that can make a difference and a change, but there's still a long way to go. And I know that we have done a technology pilot, a short kind of evaluation of the impact of technologies like C3-Cloud. And I think it is, as I was saying, our intention to continue that work in the future. And I think we need to do it, as all the previous speakers said, in the various aspects of the elements we discussed. We need to do it as a big group. We need to work together on that. So I think that's my basic point for this challenge. Maybe if, I don't know if Tim would like to say a couple of things.
Absolutely, and I think most importantly would be, oh sorry, my webcam's just turned on. I think the most important thing is what Dipak Kalra said about the pathways and processes that had innately been developed, that were part of an organizational culture that perhaps no one can really remember quite how those processes and pathways occurred. And actually, when you sit down as a group to rethink them, you actually question, why on earth do we do it like that? But there are barriers, and the reimbursement barrier is a big challenge, I think, to clinicians about completely reinventing those pathways from scratch. But without focusing too much on COVID, I think some of the things we've seen during the COVID pandemic is that COVID just tore apart those innate pathways that we had. So they created complete disruption, and we completely pivoted the hospital to look after respiratory conditions, and not just the hospital, actually primary care, secondary care, even NHS 111 services, look after respiratory conditions. And we're in a really interesting phase now where we're looking at whether we go back to where we were before, and people are questioning, why on earth are we going back to those convoluted processes and pathways? I mean, one of the big pushes, I think, nationally is direct access pathways. Because the direct access pathways allow people to avoid infection-prone waiting rooms, waiting areas, A&E corridors, and that sort of thing. And actually, we're in an opportunity now where people are actually starting to rethink, why on earth did we get to that process in the first place? So I do think it's a really exciting time. But the question is when reimbursement comes, and that gets questioned, particularly perhaps next financial year, because we've had a bit of leeway given COVID, whether then actually we creep back to our old habits.
Excellent, thank you, Tim. I think at this point I would like to suggest, Dipak, that we close this session, and maybe.
Thank you, Theo. No, that's great.
If there are further questions as we talk about the next steps, we can bring them to the closing session. I would like to thank again everybody in this session, Nathan, Gunnar, Tim, and Dipak, for their contributions.